Well, this is an interesting one. Billy Mallon wrote this again, and those of you who know Billy, he did a tropical medicine fellowship in Peru, and with good reason. He's at LA County, where tropical medicine is sort of a lot of what they do. So it has an interesting approach, and the issue of illness in the traveler is one of those, I don't think all of us can remember all of the details of what to do. I think the bigger thing is, when do you activate getting back to things that you don't use very commonly, and where can you look things up? I think his initial point was really good. Most common serious problem with travelers is trauma, auto accidents, all that kind of stuff. But back to what happens to once they get to your emergency department. Most of this is a sort of northern hemisphere focus. I don't know that it would be much different for those practicing in the southern hemisphere, because most of the things people talk about are tropical illnesses. There's lots of good sort of quick take-home messages in these things, so I'll try to hit those fairly hard. The first topic here, what's the latest with travelers' diarrhea? Well, the latest here are articles from the mid-90s, and so it's not really the latest. But I think the issue is still, is it worthwhile to use empiric antibiotics when somebody develops traveler's diarrhea? I think the simple answer is yes. And in most of these, it decreased the frequency of having liquid stools by some 30 hours or some up to 2 days. Most of the recommendations were, after the passage of 2 or 3 liquid stools, you take the Cipro or the Naroxen, something like that. That's when it starts, and that's probably reasonable. You only need it for a couple of days, and it's probably effective. So that's sort of the take-home. I don't think that recommendation has changed much. How about anti-motility agents? This was always the great, you can't give anybody these anti-motility agents, because then you keep all these evil humors in the bowel, and then you get invasive disease, and it's really bad. For years, people thought this, and I think most of the recommendations, even among those who were staunchly never give an anti-motility agent, now say it's okay to do unless they have bloody diarrhea or they're severely ill. And those people, it's probably not going to be go home anyway. So I think we can use the anti-motility agents. Do they work in the face of using antibiotics in addition? Yes, but it's a small difference. So if you're nervous about it, it's not such a bad thing to hold off on doing it, but they probably do work, and they're okay. Most of the studies about this are what I've called the we did it, we liked it kind of things. Yeah, we give it out, nobody seems to get seriously ill if we do it, and they get some mild benefit. And most of them are old. All right, what about methylene blue and guaiac testing? How many here, if they see somebody with, not necessarily even traveler-related, a diarrheal illness, will order studies on the stool day 1 of presentation? Now, most of us don't do it anyway. So it's the ones who would prolong things where you might like to think about, do they have a bacterial cause or not? How many here would order studies, get something that they do? How many just treat if they need to? Yeah, I think treating is where most of it goes. The studies on methylene blue, Billy laments the fact that we don't have microscopes in the ER anymore after CLIA. That hasn't bothered me so much. I don't like necessarily looking at all that stuff anyway, but our lab can do it if we want it. So there's a couple of studies in here, and how good is a right stain or methylene blue stain looking for fecal leukocytes at predicting a bacterial infection? It's not bad. 82% sensitive, 82% specific. That's not bad. It's not great. I mean, those aren't real high, but they're not bad. And then when they look at those that had bacterial and looked at what were the symptoms that most prominently came when they had a bacterial cause for their diarrhea, mucus in the stool, blood in the stool, fever. So those are the things that we know and we've associated with bacterial infections. So that was fecal leukocytes. In the next study, it wasn't quite as sensitive, except in children for some reason. Seemed to have a good sensitivity and specificity. Always be careful. I know it was mentioned in the methodology section. When somebody tells you the positive and negative predictive value and has a very high negative predictive value, they're trying to sell you on the test. And all they've done is they've tested it in a low frequency population. So if, they say, gosh, the negative predictive value is 95%, but only 5% of the people they tested had the illness, it's no better than nothing. So beware of that. They should give you sensitivity and specificity if you really want to know something, or likelihood ratios, even better. Then they compared fecal leukocytes to just doing occult blood testing in the stool. And that was almost as good. They say it's a lot cheaper, a lot easier, that kind of thing. So if you feel compelled to do a test and you want results immediately, occult blood testing is not bad. In children, at least, it had a fairly good specificity, so you can say they probably don't have it if you need to. How many here have had people question about the peanut butter stuff? Anybody getting that as questions? Yeah, have you seen any that related? No? It's interesting how that stuff goes around so quickly. You see the routine everyday vomiting and diarrhea stuff, and now all of a sudden you've got to address, to me it's with the parents, do I have to ask you about peanut butter? And that kind of stuff with the salmonella. Sort of as a sidelight, our health department's been asking us to get stool culture testing in these folks so we can see if we're having that. At least my big question is, so who's paying for that? If you ask the patient, you're not going to change therapy most of the time based on cultures anyway, and a few $100s worth of that, self-insured, paying their own stuff, or they're in their copay, I think it's not reasonable to ask patients to pay for public health testing. I think the health department should pay for public health testing, and I can't convince them to do that. So we have a program where our hospital will not charge if we're doing it for public health reasons, which seems fairly good. All right, typhoid fever. There's an article here on it. Some interesting, these are 3 patients that had the country of origin being the U.S. These are LA County kinds of things. Most did not have the diagnosis made in the emergency department. Most were admitted, and then somebody made the diagnosis based on stool culture testing or something else. I think this is one of those, think about it, but I don't know that we're independently going to diagnose that. Did anybody here diagnose typhoid fever in the last 10 years? Yeah, so I think it's one of those, gee whiz, keep thinking of it. Vectorborne diseases. Now this is the thing where I think the issue for when do we think rare illness in the face of common symptoms is the biggest single challenge in emergency medicine. We see common illness every day, headache, myalgia, fever, aches and pains, vomiting, diarrhea, and most common things are due to common illnesses. So the question is, when should you get your antennae up for red flags for thinking unusual stuff? I think that's sort of the day-to-day challenge in emergency medicine. And the one that I think does bring that out is to routinely take a travel history. If somebody says, oh, I just got back from sub-Saharan Africa, all of a sudden your thoughts about their febrile illness will change. Then the bigger question is, I used to always ask the question, had any recent travel? And then the best response I got was, how recent is recent? So how recent is recent enough to consider something that they got overseas? How far out do you go? A month, 2 months, 6 months? A year is what most people talk about. In one of these things here for malaria, 2% of the cases presented after a year away from their travel. For those in the states who take the boards, last year in the LLSA reading list, I think it was last year or the year before, there was an article from New England Journal on fever in the ill traveler. And that was the thing that brought to me, I've got to really think about a year for malaria. We'll get into the malaria stuff in just a little bit, but that was the main take-home message from that. If you're taking a travel history, it can go out to a year, and then depending, obviously, on where they went. I think the next thing to think about, without getting into the specifics yet of the diseases we're thinking about, is once you're starting to think tropical illnesses, and you can't remember all the, does dengue fever have the low platelet count, or is that only malaria, or actually what's dengue fever anyway, and trying to remember all those things. What's the workup that you get started so that when you talk to your infectious disease specialist or travel medicine person, you've got the database that you need, and Billy's listed it in here. You need a CBC. Actually, this is one of the times I actually have a big anti-CBC mentality. I think there's lots of people who think the CBC is the way you measure badness in medicine, and I think that's not true. I had a talk that I used to present called The CBC, the Last Refuge of the Intellectually Destitute. Thinking that, if their white count's up, there's something bad, and if it's not up, it's not the case. And of course, we all know great big exceptions to that. Meningococcemia, the lower the white count, the higher the mortality. There's all kinds of things that are exceptions to that. The surgeons always do it. They titrate what they do based on the white count, minute by minute kind of stuff, things that don't make any sense. This is the other big exception, though. Tropical medicine stuff, the numbers do actually have fairly good likelihood ratios for things. So this is one case where the CBC is actually worthwhile. Stool cultures, thick and thin smears are things to do. Liver functions tests, chest x-rays, blood cultures. With that, he thinks that and a fairly good history, you can probably nail down most of the things that you need to do. So there's a bunch of studies in here that are from Europe, most of them, and they take people who have been traveling and they present with a febrile illness, and then they go through and they say, what did we find? What are the kinds of things that we find in these people? The one take-home message is that about half their febrile illness is not related to travel. They have common domestic UTIs, pneumonias, that kinds of things. So that's one thing to think about, is just because they've been in Africa or South America doesn't mean that their febrile illness is related to that. So that's the one take-home message. The next one, 14, is one to put a star next to and actually read, because he has lots and lots of good stuff in this. This is a Belgian study where they had 2,000 people with episodes of fever after travel. 15 is actually the same author with the previous study with only 1,700. So this was just his later one. So tropical infections in 41% of the early onset episodes and 30% of the later episodes. And of the later episodes, malaria, 86%. So malaria is the one you think about months and months later. Actually, malaria is the number one to think about regardless. So a couple of things there. They give likelihood ratios for all of the factors that they did. If they went to Latin America, the likelihood ratio for a non-malarial illness of 29. That's a huge likelihood ratio. A lot of the others aren't that big. Thrombocytopenia had a likelihood ratio of 2 for dengue fever, not all that much. Enlarged spleen, Salvation Pacific travel, things that are just make you lean in one direction or another with patients in this category, I think are worth doing. So malaria, non-falciparum, was responsible for 84% of the cases that became symptomatic at least 3 months after arrival. So that's the one to think of if it's really delayed. Dengue fever, how many here have seen dengue? And where do you practice? In Australia. And it's epidemic where you are? Uh-huh. Oh, is that right? Okay. Yeah, so the Mediterranean, the Caribbean, we see lots of Caribbean travelers, cruise ships, that kind of stuff. Caribbean, for those of us in the U.S., they can get that. I was actually just in Barbados, and they have plenty of dengue there. So dengue fever, they have it Southeast Asia, India, Central South America, Caribbean. Most had leukopenia, most had a low platelet count, although not terribly low in most of the cases. So that's one of those things where you think the platelet count is one of the things to think of, but it's not less than 10,000 and less than 10%. And you can get serologies for it. So that's one thing to think of. The trouble with all of these is they all sound alike when the symptoms come out. Headache, fever, myalgia. The one thing with the fever, if it's been long enough, if there's something cyclic about it, bad fever, off for a couple days, drenching sweats, bad fevers coming back, the cyclic thing to think malaria, although I think in most of the articles here, not that many people had that kind of cyclic pattern. The take-home messages on malaria here I thought were interesting. The one that's called airport malaria. So somebody travels to an area where malaria is not endemic, no problem. However, the plane that comes to pick them up travels from the endemic area, lands at their airport, the mosquitoes are on the plane that give it to them, and so you wouldn't suspect that they should have malaria because they weren't in an endemic area. So that's one sort of take-home message. So continue to think about it in patients not necessarily from endemic areas. In most of the studies here, there's some Israeli studies and some other studies. They said most of the time if it wound up being malaria, and that was still the most common one, they either did not take prophylaxis, they didn't take adequate prophylaxis in any way, were most of the cases, like 80% or more, just aren't doing the right things. Or they went to an area that they didn't think was endemic for malaria, and they were. This actually happened to me on a trip many years ago to China. And where the tour was supposed to go, there was no need for malaria prophylaxis. However, midway through the tour, they changed one of the destinations, something with the hotels and that kind of stuff. And then you arrive in this new rural area, and you walk in, and there's big mosquito nets everywhere in the bedrooms. And then all of a sudden, people are swapping malaria prophylaxis pills with each other. All right, so thrombocytopenia and malaria. Half have low platelet counts in some of these. Delayed onset malaria, again, same thing, up to a year. All but 2 patients had received no or inadequate anti-malaria prophylaxis, so that's something to think about. Mefloquine, is anybody still prescribing Mefloquine? Any of you guys do travel medicine? Prescribe stuff for people? But Mefloquine was one of the ones prescribed, and people go crazy on it. Even there's real psychiatric disease is one of the contraindications, and a fair number of people had psychiatric symptoms while on it and traveling. Actually, my daughter had some of this, and dreams were amazing, just amazing dreams. Actually, she said once you got used to the fact that it was the medicine, it was kind of, entertaining, if they weren't terribly bad. So I don't think we use Mefloquine routinely. A lot of countries have pulled it off the shelf. All right, the economy class syndrome. This is interesting. I didn't really know the history of this. Went back to the bombing of London, where people sat in bomb shelters for hours, and people recognized that they were getting DVTs and PEs as a result of that. So the numbers that are tossed around are about 5 to 6 hours seems to be the median time when people have had some sort of cramped travel, whether it's car travel or air travel, and some people get their PE walking off the plane. Interesting how that is. So one thing to think about in the traveler, the thing that I would love to know, one, how common is this? All of these have, here we had a few cases, and here we have a few cases, and here was the duration, but what about all the ones, how many people are flying, and how many people then actually get it? I don't think we know, because that would then speak to, should we think about, does aspirin work? Some people in here even recommended heparin. It'd be hard to recommend heparin without knowing how bad this is. Maybe one of the risks was if they obviously had other risks for DVT, what should you think about in terms of travel? How many here are for long flights take an aspirin beforehand? Yeah, I know I do. I don't think there's any reason not to. But this is just one of those, now think about it in terms of travel history, in terms of other illnesses that they get. Billy mentions if people are interested in tropical medicine, he has fabulous stories of his tropical medicine time. I mean, it is really old-fashioned medicine too. I mean, it's just examine the patient, go look at the microscope, make the diagnosis. Nothing else they have, and just thousands of patients that can come through to get all this experience with. I suppose if you're going to work at LA County ER, you probably need that. At least where I am, you really don't. The EM prep notes here that he's included in the back of it, this is the New England Journal article that was in the LLSA reading. It's way too detailed to go into, but it's actually an excellent just review of all this stuff for, if you have a 5-hour plane trip home and you need something to read while you're developing your clot in your leg, you can go through these and see it. But I think that's about all I have.